It's going to fit on one cassette, so you're going to use two 14 by 17s. First run, you're going to put top of the light fill to ASIS. Rotate the leg in 15 to 20 degrees. Show a little bit of collimation marker. You don't need to shield on that one because it's going to be covering a gonad. Don't move. Beat. Now for the rest of the femur, take the foot, drop it out a little bit so it's only 5 degrees. Go a little bit below the knee and up as high as it'll go. That one you can shield because there's not going to be any light on the gonads whatsoever. Don't move. Beat. Then you need a lateral femur, so they're going to roll over onto whichever side that it is. Make sure that the patella is on profile. You're going to have about a 45-degree flexion and do the same thing. ASIS down, don't shield, beat, and then kneecap up, shield, beat. AP pelvis is going to be a 14 by 17 landscape. Central ray is midway between ASIS and pubic symphysis at MSP, but cheat is just put the top of the light field right on crest. You will get everybody's. Make sure the last thing you do, put a marker. If you have a little teeny person, which I'm sure everyone's going to use for their patient, you're probably going to have some light here. If you don't, you have to put it on the patient. Last thing you do before you walk out, pigeon toe, 15 to 20 degree medial rotation, which gets rid of the lesser trochanters, makes them not visible. Hold your breath, beat. Okay, AP hip. If you pick a, let's say, left hip, it'll say left AP hip. You're going to use a 10 by 12 over here. Central ray is mid-femoral neck, which how do you find that? Start at ASIS, go 1 to 2 in, 3 to 4 down. Put it right there. You need to use a left marker if you're doing a left hip, right marker if you're using a right hip, before you beat 15 to 20 medial rotation. Can't shield. Beat. Then you're going to pick a left modified cleaves or a left frog leg or a left lateral hip. Then that's just where you take the leg and you abduct out 40 to 45 degrees. Central rays in the same place, mid-femoral neck, can't shield. Beep. If you pick a bilateral frog leg or a bilateral modified cleaves, 14 by 17 landscape, both legs abducted 40 to 45 degrees, and your central ray is MSP and 3 inches below ASIS. Don't breathe. Beep. Next one, AP outlet. So that is to look at bilateral pubes and ischia. Little 10 by 12 cassette at the bottom there. If it is a male, you're going to angle the tube 20 to 35 degrees cephalic. Female, 30 to 45 degrees cephalic. Central ray enters 1 to 2 inches below pubic symphysis. You're not going to feel for pubic symphysis, so find greater trochanter, and at that level, 1 to 2 inches below that. Hold your breath. Beep. Okay, then we need an inlet. Everybody is a 14 by 17. Everybody's 40 degrees caudad. Central rays at the level of ASIS. Hold your breath, beep. That's to look at the pelvic brim. Then you got posterior obliques for acetabulum or Judae. If I want to look at my posterior brim, whether it's right or left, put it up. So an LPO will demonstrate my right posterior brim and my left anterior brim. And an RPO demonstrates my left posterior and my right anterior. For a central ray, if I'm doing the upside, all I'm going to do is take my ASIS and go 2 inches inferior. That's my central ray. If I'm doing my downside, I'm going to go 2 inches inferior, but also 2 inches medial. B. Axiolateral hip, that is replacing the modified cleaves. If the patient can't do this, we're going to leave it this leg down, the injured leg. We're going to hike the other leg up on the tube. We're going to make the cassette parallel to our femoral neck, which is about a 45-degree angle. And then there's no tube angle, and we're going to take our central ray and make it perpendicular to the IR and the mid-femoral neck. And we're going to take the injured leg, and if they were able to 15 to 20 it on the AP, they can still 15 to 20 it for the axiolateral, or the Danny Miller. Last one, we want to do a lateral hip, but the patient just got out of surgery, or they fell and they injured both hips. So we need to somehow get a lateral, but we can't hike it up there. We can't do this. So we're going to leave their legs down. We're going to have them 15 to 20 medial rotation. If I'm doing a right hip, I'm going to take my image receptor and angle it or drop it back 15 degrees. Take my tube, angle it 15 to 20 degrees, and enter right on the mid-femoral neck and throw it onto the image receptor. baby.